The following podcast is part of a certified educational activity titled Restoring Remission in RRMM, Present and Future of Sequential Immunotherapy with GPRC5D Targeting Options. Access the entire activity and complete the post-test at peerview.com/ESB860. Downloadable slides and practice aids are also available.
Hi, my name is Shaji Kumar. I am a hematologist at Mayo Clinic. Welcome to Restoring Remission in Relapsed Refractory Multiple Myeloma, Present and Future of Sequential Immunotherapy with GPRC5D Targeting Options. During the activity, I will share evidence supporting established and emerging GPRC5D directed immunotherapy in previously treated multiple myeloma and provide insights on how we can use these options in sequence with other important therapies, including CAR T and BCMA targeted bispecific antibodies. Throughout the program, I will note several downloadable practice aids that can be used to provide quick insights on practical considerations with GPRC5D targeted agents. So please download these resources before we get started. Let's begin. Our goals for today is to help you understand the biology of GPRC5D in the context of therapeutic targeting in multiple myeloma, to improve your knowledge of the mechanisms and efficacy evidence of non-BCMA targeted immunotherapies in relapsed refractory myeloma. Enhance your skills for developing personalized sequential treatment plans that feature non-BCMA treatment options in relapsed disease. And finally, to provide you with guidance on team-based safety, dosing, and other practical aspects of care with team-based strategies to address practical delivery considerations with GPRC5D based treatments in myeloma. We would like to thank our partner, HealthTree Foundation for Multiple Myeloma, for supporting this activity. The HealthTree Foundation provides personalized support and tools to navigate myeloma, both in terms of education, allowing resources or access to resources for clinical trials, as well as other patient support activities. The HealthTree has a registry that enables transformative research in blood cancers for providers and researchers looking at improving the outcomes of patients with multiple myeloma. You can scan the QR code to learn more about the registry. And the patient support programs are all accessible online. And again, you can use the QR code to take you to the web page with all these different tools that can enable patients to navigate their disease. Now, we have made incredible progress in patients or the treatment of patients with multiple myeloma. Now, early 2021, we had the two CAR T cells that were approved, both ide-cel and cilta-cel, initially approved in late-line therapy in patients who have had at least four prior lines of treatments. And subsequently, there were um, two BCMA-targeted bispecific antibodies that were approved, teclistamab and elranatamab, and one GPRC5D targeted bispecific antibody, talquetamab. And in 2024, now we are starting to look at an earlier approval line for cilta-cel, where the CAR T can be used for patients as early as first relapse, and ide-cel as early as the second relapse. And there's a whole host of new therapies that are going through clinical trials, many of which are likely to be approved in the near future. And with the influx of all these new therapies, clearly the outcomes of patients continue to improve. But it also poses several challenges in terms of how we use these different treatment options in optimal manner in order to improve the outcomes of patients with myeloma. Now, there have been multiple other studies in addition to these randomized or single arm clinical trials that have looked at the efficacy and tolerability of these new bispecific antibodies. Now, these real world studies are extremely important because the clinical trials have enrolled limited number of patients with very strict enrollment criteria, and hence it's important to get a sense of how widely can we use these therapies in the real world setting. Importantly, there have been three specific trials. One is locomotion study and the two moment trials, all of which have enrolled patients who are similar to those who have been enrolled on the clinical trials with these agents. And these patients are often refractory to the standard of care agents, including the immunomodulatory drugs, the proteasome inhibitors, and also anti-CD38 monoclonal antibodies. And in fact, these real world studies have highlighted the need for having these new therapies. In fact, when you look at some of these studies where patients have been exposed to variety of different standard of care therapy, you can see the overall survival in this patient population is often about a year, and the progression-free survival with the non CAR T therapies or the standard of care therapies is about 3 to 4 months, and the responses are seen in only about a quarter to a third of these patients. That brings us to the value of GPRC5D and the biology behind targeting GPRC5D in patients with relapsed multiple myeloma. Now, just as we have seen with many of the other antigens that we target, like CD38 and BCMA, GPRC5D is also highly expressed in myeloma cells and is quite abundant in the bone marrow plasma cells as well as plasma cells outside of the bone marrow. The expression of GPRC5D and BCMA are quite similar in these myeloma cells, and the expression patterns, in fact, are independent of each other, which is very important because it is critical for us to have these immunotherapy approaches that targets different agents or different antigens on the myeloma cells. What is also important as we learn more and more about the resistance mechanisms in patients who are receiving BCMA targeted therapies, whether it be antibody drug conjugates or T cell redirecting therapies such as bispecific antibodies and CAR T. Um, the patient myeloma cells can lose the expression of the BCMA, or the BCMA might still be expressed, but they have undergone structural changes that makes it impossible for these BCMA targeted agents to bind to them. However, in those patients, the GPRC5D expression continues to remain high, enabling us to leverage other um, uh, immunotherapies that are targeting GPRC5D for these patients. Talquetamab was the first bispecific antibody that has been approved for targeting GPRC5D. Just as with other BCMA targeting bispecific antibodies, this is again has dual target. It is able to bind to the myeloma cell through the expression of GPRC5D on the myeloma cells and simultaneously to the T cell through the CD3 recognizing epitope. And these then bring the myeloma cells and the T cells close to each other, resulting in the immunological synapse formation, leading to T cell activation, cytokine release, and eventual myeloma cell death. And these mechanisms are very similar to what we have seen with other bispecific antibodies as well. So let's talk about this whole concept of sequential approach to these different immunotherapies that are targeting different antigens. Now, we have to think about it in the context of how the patients with newly diagnosed myeloma as well as patients with relapsed multiple myeloma are currently being treated. One thing that is very clear is many of the progress that we have made and the discoveries over the past 2 decades have been very well integrated into the current treatment algorithms. So, for example, when you look at the this particular approach that is employed by the Mayo M-SMART guidelines, you can see that patients with newly diagnosed transplant eligible, um, newly diagnosed myeloma who are considered eligible for an autologous stem cell transplant, these patients, if they are standard risk or high risk, they get a quadruplet induction and a CD38 monoclonal antibody with proteasome inhibitor, lenalidomide, and dexamethasone. And those patients with standard risk uh, uh, can either undergo an early autologous stem cell transplant, or they can collect and store the cells for a future transplant and then go on to maintenance. And those patients with high risk get similar induction therapy. And subsequently, we encourage those patients to have early autologous stem cell transplant followed by a two-drug maintenance. In contrast, patients with newly diagnosed myeloma who are considered ineligible for an autologous stem cell transplant get a three-drug combination, typically like retimumab, lenalidomide, dexamethasone, But recent clinical trials have suggested that many of these patients up to 80 years of age can also get a quadruplet therapy that incorporates uh, all three classes of drugs, like the transplant eligible patient population, and with outcomes that are quite superior to what we have seen in the past with the two and three drug combinations. Now, when we start thinking about the disease relapse, often those patients in the first to third relapses are treated with combinations that incorporate the anti-CD38 monoclonal antibody with proteasome inhibitors and immunomodulatory drugs, again, using different drugs from within the same class to create triplet combinations that will allow sequential use and also maintain the disease in remission for long periods of time. Now, what has changed is the ability to use novel therapies like CAR T-cell therapy much earlier than what we had initially studied and was approved. For example, cilta-cel or cilta-captogene autoleucel now has a Category 1 designation in the NCCN guidelines for patients in the first relapse. But in the real world practice, most of us tend to use the cilta-cel in the first relapse in very limited subset of patients with high risk disease or patients with more aggressive early relapse. After two prior lines of therapy, we can use either of these CAR T cells, including idacaptogene viculeucel or ide-cel, as well as cilta-cel. And this is one place where we are increasingly starting to use CAR T cell therapy for patients with myeloma, again, taking into account the underlying disease risk as well as other treatment related characteristics. Now, what about patients beyond the first 1 to 3 prior lines of therapy? Now, right now, we have, as we already mentioned, we certainly can use the CAR T cells if they have not been used already. There are certainly three bispecific antibodies, elranatamab, teclistamab, and talquetamab, that have been approved for patients in these late relapses. Now, the question then comes up, how do we sequence all these different immunotherapies? Talquetamab, the GPRC5D targeted bispecific antibody, was approved based on the efficacy in the Monumental 1 study. The long-term results of the trial was presented in the past year and showed deep and durable responses with talquetamab in patients with relapsed refractory myeloma. And it is important to remember that majority of the patients were triple class refractory, and the overall response rate in the overall cohort was about 70%. And if you look at the subgroup of patients who had received previous T cell redirection therapy, 52 of them, the overall response rate was marginally lower at 67%. And it's important to look at the depth of response as well, because almost 60% of these patients, the vast majority of the patients who responded to therapy, had a very good partial response or better, and a third of the patients were able to get to a stringent complete response. Depth of responses that we have not previously seen with other treatment modalities before the advent of immunotherapy. It is also important to highlight that these responses are quite similar to what we have seen with other bispecific antibodies that target the BCMA. And as with teclistamab and elranatamab, nearly 60 to 70% of the patients treated with talquetamab also responded. Now, of course, we want to look at data beyond just clinical trials. And there was a real world study that was presented with rather small number of patients, but again showing that in the responses in the real world setting seems to be quite consistent with what was seen in the clinical trial, with an overall response rate of about 70% and a CR rate or a complete response rate that's quite close to about 30%. And those patients who received prior T cell redirection therapy versus those who did not appear to have relatively similar response rate, again highlighting the importance of going after an antigen that is different from BCMA. When you look at the side effects, and this is one which we need to be quite cognizant of, because even though there are some adverse events that are similar across all bispecific antibodies, we will always encounter adverse events that are quite specific to the antigen that is being targeted. So, for example, when you look at the key adverse events associated with talquetamab, the incidence of cytokine release syndrome is about 77%, mostly grade 1 or 2. It's very similar to other bispecific antibodies, low rate of ICANS compared to CAR T cells, and again, mostly grade 1 or 2. And there's also the risk of infection that we see with all bispecific antibodies. What is unique about talquetamab is the skin and GI-related toxicity, again, because of the expression of GPRC5D in tissues beyond the plasma cells. So the administration of talquetamab can be associated with a dry mouth, difficulty in swallowing, as well as alteration of taste, all of which can lead to weight loss as well because of the decreased intake. In addition, you can have skin and nail changes, including rash as well as nail related adverse events. And again, many of these can be seen in anywhere from a third to two-thirds of the patients with talquetamab therapy. Um, it is important to note that most of these adverse events tend to be grade 1 or 2, with a very limited grade 3 for adverse events seen with respect to rash and weight loss. And the important thing to also highlight is that vast majority of the symptoms resolve, some with dose modification, some over time, but overall leading to a very low rate of discontinuation. And we will talk about the dose modifications in more detail later on. Now, just as what we have done with the teclistamab and elrantamab, where increasingly we are exploring combinations with the standard of care agents, similar approaches has been taken with talquetamab as well. Talquetamab has been combined with immunomodulatory drugs like pomalidomide and a CD38 monoclonal antibody like daratumumab, and most importantly, with BCMA targeted bispecific antibodies. So, looking at a combination of bispecific antibodies that target two different antigens. Now, the redirect one trial actually looked at the combination of teclistamab and talquetamab in a cohort of about 94 patients and showed very high response rates of almost 80%, with almost half of these patients achieving a complete response or better. And the responses were quite durable, lasting beyond 2 years in majority of these patients. Again, highlighting the ability and the efficacy of combining two different bispecific antibodies going after two targets simultaneously. Now, obviously, there are ongoing clinical trials now starting to look at the use of talquetamab-based combinations in a phase 3 setting. So, in the Monumental 6 trial, we are looking at talquetamab combined with teclistamab, like redirect one with pomalidomide, or with a standard of care control arm to make sure that we can that these trials will lead to approval of these combinations. Now, as with myeloma, whenever we see a drug that is quite effective in the setting of relapse disease, we would like to try and take it into an earlier line of therapy, maybe even with newly diagnosed myeloma patients. So, here we have some early results, albeit limited number of patients, where talquetamab was combined with daratumumab and lenalidomide in newly diagnosed myeloma patients. And these results, which are present at the ASH meeting in December last year, you can see that almost all the patients achieve a response to the combination of talc, dara, len, and importantly, an impressive 81% of these patients had a VGPR or better. So this appears to be quite effective, and obviously, the phase 3 trials in the future will tell us whether this represents a acceptable approach in the first line therapy, primarily from a toxicity standpoint. So now it's clear that we have a tool in hand that is quite effective, an effective therapy in the form of a GPRC5D targeted bispecific, which is talquetamab. And the important question for us remains, how do we use this particular set of drugs? And it's important for us to understand this because there are other GPRC5 targeted bispecific antibodies and CAR T therapies in development. And what we um, learn currently will certainly be applied to the use of those agents as well. Now, for example, one of them is forimtamab, which is a GPRC5D targeted bispecific antibody, and the initial studies again demonstrates activity which is quite comparable to talquetamab. Overall response rate in this particular group of patients giving IV for imtamig was about 71.4%, and patients getting subcutaneous therapy was about 64%. And importantly, majority of the patients achieving a complete response which is about a quarter to a third, were able to achieve MRD negativity, again highlighting the efficacy of this particular one. As was mentioned, we also have CAR T-cell therapies that are being developed, which is targeting the GPRC5D. The MK109 is in clinical trials. In the first set of patients, it was quite effective. Oricar 017 is another one that is currently going through clinical trials as well. While there are differences in terms of the dosing strategies for these in terms of doses, all of them appear to be, at least the initial data supports high activity in these CAR Ts. And finally, there's the BMS 986393, which is also a next generation GPRC5T CAR T cells that are going through clinical trials. So let's take a look at some of the available data. This is data with the 986393. This one particular one is again manufactured using the next technology. The approach is very similar to what we have been using in the BCMA targeted CAR T. Particular clinical trial looked at patients with relapsed refractory disease who have been exposed to at least 3 prior therapies, including prior BCMA directed therapies, and that may have included CAR T cell therapy. Very similar approach, patients get screened, they get leukapheresis, they can get optional bridging therapy, and then undergo lymphodepletion with fludarabine cyclophosphamide, followed by reinfusion or infusion of the modified CAR T cells. And the primary objective of this trial is to look at the safety and tolerability as well as the early efficacy. The initial 79 patients who were treated with this, you can see that the overall response rate was 87%. If you look at the 23 patients who were treated at the recommended phase 2 dose, nearly 90% of these patients responded, including half of the patients achieving a complete response. Now you can see that the response rates seem to be quite independent of the underlying disease characteristic, whether it be high risk cytogenetics, extramedullary disease, or triple class refractory. They all appear to respond in a similar manner to the treatment, with about 80 to 90% response rate. There seems to be a little bit of a drop off in the response rate from about 95 to 79% in patients who previously had BCMA targeted therapy, which is not surprising, knowing what we have seen so far with other similar approaches. So let's take a look at how can we effectively deliver these class of therapies for patients with myeloma, specifically focusing on the team-based approach in delivering effective immunotherapy for our patients. Now, increasingly, it's evident that a comprehensive care of patients with multiple myeloma requires a true team approach. Obviously, the hematologist or the hematologist oncologist taking care of this patient have to make critical decisions in collaboration with the patient in terms of specific therapies and how we sequence them. But given the disease-related complications that can arise in patients, as well as the adverse events associated with these type of therapies, we will need to engage a multi-specialty, multidisciplinary team for our patients. Clearly, the involvement of the oncology nurse, social work, as well as a psychiatrist or psychologist can be important, given uh, the logistics involved, the adequate education regarding the management of adverse events, as well as other impact of these therapies. Now, clearly, for example, when we talk about something like talquetamab, which can affect the ability to um, maintain your nutrition because of altered taste, or other things like dry mouth, it may be very important for us to involve the dietitians as well as the nutritionists, because they will have tips for the patients to adapt their intake to get over these problems. Similarly, the severe skin rash that can sometimes happen in patients receiving talquetamab may require us to consult with a dermatologist in order to conservatively manage the skin-related and nail-related side effects. The dry mouth related to some of these therapies can lead to, again, poor dentition, which can then be um, may need again consultation with the dentist as well. So let's take a look at a patient example, for example, in order to better understand the whole concept of sequential choices of these different agents. So Susan is a 76-year-old patient with myeloma who started off with standard recited genetics and now have had 4 prior lines of therapy as outlined here, having received a quadruplet therapy in the frontline setting followed by stem cell transplant, and then received a carfilzomib Blendex, then selinexor bortezomib dex, and finally received a CAR T-cell therapy targeting BCMA as the fourth line therapy. Unfortunately, she did not get the type of response we would anticipate with the CAR T, with having a disease progression happening within the first year after infusion. So clearly now the disease is relapsing and we need to intervene. So the question that often comes up is, what would be an appropriate therapy to use next? Obviously, the standard non-immunotherapies have all been exhausted in this patient, so doesn't make much sense to try those, at least in the long-term sense. Then, if you were to think about immunotherapies, then the choice is between using, so doesn't make much sense to try those, at least in the long-term sense. Then, if you were to think about immunotherapies, then the choice is between using, doesn't make much sense to try those term sense. Then, if you were to think about immunotherapies, then the choice is between using, doesn't make much sense to try those term sense. But to think about immunotherapies, then the choice is and as we go through some of the logistics, especially with the step-up dosing, this raised quite a bit of concern with respect to travel. And I think this represents another important aspect of treatment with these immunotherapies. As we already mentioned, cytokine release syndrome is very common among patients getting bispecific antibodies and CAR Ts. And this requires uh, a very close monitoring of patients as they're getting these immunotherapies. In addition to this cytokine release syndrome, the neurological toxicity can also happen, and hence the initial treatment is often done in the context of a hospital setting. Now, in CAR T therapy, a significant proportion of patients stay inpatient during the initial therapy if the institution does not have an outpatient-based approach. In institutions which have outpatient-based approach like ours, we often tend to treat patients with CAR T in the outpatient setting as well. When you think about the bispecific antibodies, obviously the severity of these reactions, including cytokine release syndrome and the neurological toxicity, is not as high as what we see with CAR T. But nevertheless, the frequency is high enough that we need to watch these patients closely. Now, some of the attempts at trying to reduce the frequency of the cytokine release syndrome has been to use a step-up dosing by starting with a small dose and giving a slightly higher dose subsequently a week later or a few days later, and then giving the full dose after a few more days, allows us to reduce the overall rate of cytokine release syndrome. However, that does mean that patients have to remain close to their treating institutions for almost 2 to 3 weeks. So there have been different approaches that have been evolved over time, and these have included prophylactic administration of drugs like tocilizumab, step-up dosing, use of steroid medications as prophylaxis, as well as the use of remote monitoring approaches to allow patients to avoid inpatient stay. So I think it's important that we have a collaborative approach towards enabling our patients to get the bispecific antibodies, and clearly that's going to involve collaboration with the referring physicians as well as the referral institutions in order for patients to maybe start therapy at the larger institution and then moving on to community to continue with the therapy subsequently. But what is also important as we start talking about the bispecific antibody treatments is to make sure the patients are well educated in terms of the potential toxicities, including cytokine release syndrome and other toxicity. And I think this is important because as patients go back to the community and they develop toxicities, particularly the delayed toxicities like cytopenias or infections. Again, it's important for patients to go get medical attention soon. And uh, the collaborative approach with the treating community hematologist will allow the patients to get optimal therapy. So again, the toxicities that are associated with talquetamab, there are a variety of different resources out there that can be used to monitor for toxicities, which are toxicities like cytokine release syndrome and ICANS, which often happens acutely and is common across all bispecific antibodies or immunotherapies, as well as some in between toxicities, especially neurological toxicity that need to be monitored over the first couple of weeks of starting therapy. It's important that patients are well educated so that they can report these symptoms right away. And then, of course, longer term monitoring, particularly with respect to side effects leading to decreased nutrition. I think if you notice that the patients are not eating well and they're losing weight, it's important that we intervene earlier rather than later. And of course, similar approaches are important for us to manage many of these skin related toxicities as well as the oral or the GI toxicities. So, in terms of the management of the cytokine release syndrome, I think, as we mentioned before, some of these intervention approaches may even be used as prophylaxis. But in general, what we have done is, if you have grade one cytokine release syndrome, that tocilizumab can be used. Um, but typically, with grade two and higher, it is important to use tocilizumab in all these patients, and these tocilizumab can be repeated if some of the symptoms persist. Now, obviously, if they have grade 3 or grade 4, then obviously additional supportive measures are needed, including the use of high dose steroids in these patients, in addition to blood pressure support as well as ventilation support. Now, the approach for talquetamab, again, very similar. I don't think the approach to cytokine release syndrome and the ICANS vary significantly between the different immunotherapy approaches. Very similar approaches can be used. I think it's important that we have patient monitoring or patient information sheets that will allow them to monitor for some of these toxicities even after they leave the primary center. So it's important for patients to be aware of the potential toxicities associated with these therapies so that they can reach out to the providers in a timely fashion. And these blank forms can be downloaded and can be used in your day to day practice, handed over to the patient so that they know exactly when to reach back to you. Now, in addition to the CRS and the neurological toxicity, management of the skin and oral toxicity requires additional measures. And again, I think it's, as we mentioned before, it's important for these patients to have adequate dental hygiene given the dry mouth that can happen with these therapies, especially with talquetamab. The alteration in the taste, you can look at simple measures like using baking soda, salt water for rinsing the mouth. Again, using soft, bland foods, especially when these toxicities are at its peak, can help patients maintain their nutrition. And also, limiting certain types of food items can also prevent this from getting worse. The difficulty in swallowing, often related to, again, the mucositis, can be dealt with by altering uh, the food consistency and also the types of food the patients take. It's important to monitor patients for weight loss because that is often a reflection of the fact that they're not getting adequate nutrition, even though they might report that they're taking adequate amounts of food items. So I think maintaining a nutrition record as well as constantly monitoring the weight is going to be important. For patients who develop skin rash and nail toxicities, I think keeping the skin well hydrated and using emollients are important. Using, again, soaps that are used for sensitive skin, and we can certainly use steroid-based creams in patients who develop severe symptoms. The nail toxicity is often in the form of, again, cracking of the nails, making it very friable. And again, these can also be managed quite conservatively by using many of the measures as outlined here. So, just to reiterate, patient education is a very important part for management of all these immunotherapies. But I think talquetamab, which is particularly relevant given the skin rash and the oral toxicity that can happen with this therapy. So, I think outlining the potential side effects, setting the expectations early on, and then encouraging them to use the tools that we talked about, as well as reaching out to the patient support groups, are going to be important. Now, one of the other approach that is increasingly being leveraged to improve the outcomes of these patients and manage the adverse event is the dose modifications. Now, it's one of these concerns that always comes up is, if we decrease the dose early on, are we going to lose out on the efficacy of these therapies? And what was seen in this presentation was that in patients enrolled on the Monumental 1 trial, even in those patients where the dose intensity was reduced in a prospective fashion, the responses were maintained. The PFS was quite similar to what we were seeing in the initial studies, suggesting that as long as patients are demonstrating evidence of response, decreasing the dose will provide you with an optimal balance between the toxicity and the efficacy with this particular type of drug. Now that we have reviewed some of those practical considerations about delivering the care with GPRC5D therapy, let's explore a patient's real life experience.
Hi, my name is Vicki, and my relationship with myeloma began in 2018 when I was found that I had MGUS. I was followed by a hematologist until 2021, July of 2021, when after a bone marrow biopsy, I was diagnosed with multiple myeloma and began treatment in 2021. Following a stem cell and other treatments, I have now been on talquetamab for over 1 year, and I am in complete response right now. When my oncologist and I decided to go to a bispecific, his reasoning was that he wanted me on talquetamab was that I would be less prone to infection, which I had been having a problem with pneumonia and flu. And instead of the talquetamab, I was given a sheet with the adverse effects of talquetamab, and I did understand them, and I was explained to me at the time about the step-up dosing. Another reason my oncologist wanted to go with a GPR5D biospecific instead of the BCME was that he wanted to keep the BCME in our back pocket because that is where CAR-T is at now. And so we weren't sure how I would respond to that. So that was another thing. And it was explained to me very well. And I did research on it on my own. So ultimately it is my choice, but that's where we went. First of all, I think patients should know that the research and development right now for myeloma is kind of going supersonic. In the 3.5 years since I've been diagnosed, it's changed dramatically. And I think it's very positive and it's great. And the second thing that I think they should know is to get as much information as they can about where they're going. And of course, it'll come from their oncologist, but also what they need to be able to advocate for themselves. That's, I'm really big on finding out what you need to know, not going too far down the road because that road is ever changing, but to have a complete understanding of what is your oncologist has, and therefore you can ask the questions and you can advocate for yourself. I first found out about HealthTree when I was searching for information on newly diagnosed patients with multiple myeloma, and came across their site, and it was so easy to navigate, and it had everything from charts to information to speakers. So I was immediately drawn in, and I found it quite helpful. The fact that they want to educate and connect patients is what I really liked. And my records are connected with HealthTree because I feel like that is so important for research, for other patients. It matches me up with people in a similar situation as mine with talquetamab. Initially, what I really enjoyed about it was their videos that explaining exactly what myeloma was. I had a good grasp of it, but I could send it to my adult children so that they could have a better grasp of it. The cure hubs and the mentoring programs, I feel, are very, very important. I know that relapse is very disheartening, that you're not quite sure what will come next, but that by staying informed about being your own advocate, you can really move forward in a very, very positive way. I once told my oncologist, my specialist, that I feel like myeloma treatments are like diets. There's so many diet books out there because everyone has a different physiology. And with all the new myeloma treatments, we just have to find the right myeloma diet for a specific person. I'm very pragmatic. I think that I don't do the what ifs. I just do, it's a chess game. What can our next two steps be? And then we go from there.
So to sum up, the whole concept of sequential therapy in relapsed myeloma, clearly a question that is becoming more important as we have more immunotherapies become available for our patients, is the importance of using not only different types of therapy like CAR-T and bispecific antibodies, and hopefully in the near future antibody drug conjugates. It's also important to keep in mind which particular target are we going after. And in addition, whether we use a CAR-T or a bispecific or an antibody drug conjugate is often decided by what the patients have had before, but also how aggressive the disease is. Can they wait for the disease control in order to go ahead with a CAR-T, or do they need to get something right away? And when you talk about these sequencing approaches, one of the important thing that is come up, and also some important data, is that we can use some of these bispecific antibodies as a bridge before patients actually go to a CAR-T therapy. So we are looking at several different scenarios. Obviously, somebody might have gotten a CAR-T piece that is targeted towards BCMA, and those patients can then go on to get a bispecific antibody, which can be either a BCMA targeted or GPRC5D targeted. There's data supporting that the response rate after CAR-T, even though it is slightly lower than compared to patients who never seen a CAR-T, is still quite reasonable. And the question remains, do we use a BCMA targeted bispecific antibody or GPRC5D targeted bispecific antibody? There are clinical trials and real world data explorations that are ongoing that will hopefully give us some important answers. Now, if patients have gotten a BCMA targeted T cell redirection therapy like bispecific antibodies, can we use a CAR-T in those patients? We certainly can. What we have generally seen is that the efficacy of the CAR-T drops substantially in patients who have previously received a BCMA targeted therapy. Um, so our preference is often to use a CAR-T before a bispecific antibody. And then the question is in someone who cannot go through a CAR-T cell therapy, can we use a GPRC targeted bispecific antibody after a BCMA targeted bispecific antibody? And that, I think, is probably the best approach in someone who cannot get a CAR-T. And then, as I mentioned, obviously, there is a small group of patients going to CAR-T where we might have to use a drug like talquetamab in order to get optimal disease control before they move on to receiving their CAR-T therapy. So, in order to conclude, this represents a major advances that we have had in the field of multiple myeloma. The past few years, particularly over the past 5 years, immunotherapeutic approaches have come into a sharp focus for patients with relapsed multiple myeloma and increasingly is being explored in the newly diagnosed setting where immunotherapy is being used as consolidation, potentially replacing stem cell transplant in some patients who are eligible for transplant, and also exploring options of limited duration therapy as consolidation in the upfront setting, allowing patients hopefully to get limited duration therapy and not indefinite therapy. But in the relapse setting, it's particularly important given that we have effective therapies to handle the disease in the newly diagnosed setting, where these quadruplets, irrespective of transplant eligibility, can be associated with deep responses and long term responses. So, when you start looking at patients who relapse disease, what the questions that are relevant are which agents to use in a particular setting, what is the sequence of these agents. And what we have seen is that the BCMA targeted therapies clearly have the maximum data that we have currently. We have BCMA targeted CAR T cells, two of them that can be used in first or second line um, you know, relapse. And then we also have three different bispecific antibodies that can be used in the later lines of therapy. We have data showing that bispecific antibodies work very well in patients who have previously received a CAR T cell therapy, allowing us to again use that in these patients who may have gotten CAR T in the first or second relapse. Now, in terms of the bispecific antibodies themselves, having two different set of bispecific antibodies targeting different antigens, BCMA and GPRC5D, allows us to sequence these two bispecific antibodies to obtain again maximum benefit. So, whether we use a GPRC5D targeted bispecific after a CAR T or a BCMA targeted bispecific therapy, both are reasonable, but I think our approach currently is to try and use the BCMA targeted bispecific antibody in patients who have previously not seen a BCMA targeted therapy if they are being considered for bispecific antibody, and using a GPRC5D targeted bispecific like talquetamab in those people who have previously been exposed to BCMA targeted agent. Obviously, a lot more needs to be learned, and especially with the real world studies that are ongoing, we will get very critical information in terms of how we best optimize the sequence of therapies. The sequencing of therapies also need to take into account the patient preferences, the logistics of receiving therapy in a larger center, and the need to stay away from home, and also the patient preference in terms of the potential toxicities that can again be different between these bispecific antibodies. The ability and the logistics of dealing with these therapies are increasingly becoming easier as we understand the approaches to minimizing the adverse events like cytokine release syndrome and the neurological toxicity, as well as the long term management of infections and other toxicities. So, in summary, I think this is exciting times with these immunotherapies for our patients with relapsed myeloma. We have some sense of how to sequence them. We have a good handle on how to handle the adverse events associated with these bispecific antibodies. We continue to optimize the ability to get these treatments in the community setting, and that is clearly a learning curve. And over the next year to 2 years, I think we will see many of these therapies being used in the community setting very effectively with good management of the toxicity and with good outcomes for our patients.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the HealthTree Foundation for Multiple Myeloma. This activity is supported by an educational grant from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC. Both are Johnson & Johnson companies. To access all materials for this activity, Visit peerview.com/ESB860.